Is being recorded.
Crazy weekend.
So, welcome and thank you for joining us today for the meeting of the New York City Health and Hospital Strategic Planning Committee. Today's meeting is officially called to order. Please note for the record, Dr. Michelle Allen is representing Dr. Mitchell Katz in a voting capacity. I would like to propose a motion to adopt the minutes of the Strategic Planning Committee meeting held on October 17th, 2022. Let me go ask for your vote individually. Dr. Allen,
Yes.
Vida Juan,
Yes.
Sally Hernandez Piñeiro,
Yes.
Dr. Patricia Martone,
Yes.
and Jose Pagan, yes. So, minutes approved. So next we will hear from Mr. Ziegler, Dr. Way, and Deborah Brown as they provide an update on the system dashboard.
Great. Thank you for having us. Good to see you all. Happy New Year. We start, as always, with a high-level overview of where we are at the federal, state, and city level.
Hello, everyone. Happy New Year. It is a busy time of year at all levels of government, or has been. Not even talking about that. I'm pleased to tell you the first order of business is the omnibus package that was passed and signed sort of end of 2022, beginning of 2023. It had a number of provisions that were very beneficial to us. We and many of our allies did a lot of advocacy in this space, particularly expands telehealth flexibilities through the end of 24, averted a pretty significant Medicare cut for another 2 years, created 200 new GME slots, 100 of which are specific for psych, which is certainly well needed. There was also an omission that was very helpful to us, something that was in play called the VALID Act, which would have created more regulations for what are called laboratory developed tests. This is something that Kenra Ford and her team are incredibly proficient in. So the absence of the VALID Act, the fact that these regulations will not go into effect, really helps us in continuing to serve our patients. The sort of marquee issues are in community project funding. This is what previously had been called earmarks. That is not the language anymore, but I know I personally slip into it a lot. We as a system were very successful. We got $10.5 million out of this process. And what this is these are individual members have the ability to fund projects within their district. And so this is really a testament to our CEOs, to our facilities, to the great relationships that they build. Certainly want to thank all the members of our delegation, especially Senator Schumer, who as ever was, there for us and on our side. So that's exciting. Looking ahead, let's all assume dust will settle from the last, week or so. What is really beneficial, I think, for the country certainly, and also for H&H, is the presence of Leader Jeffries, Representative Jeffries, though he had not actually represented what was Coney Island Hospital. He was a very ardent supporter of them, continues to have relationships with them. Now, through redistricting, they are actually in his district. And we continue to work with him and really with his staff, which is wonderful. We also have new representation, Representative Nadler, who is, of course, not new to the scene, but has, because of redistricting, has moved into our area. We're going to be hosting him at Bellevue in a few weeks. We're doing a meet and greet with Representative Goldman, who is also new to our system, and Representative Espaillat is going to be touring at Metropolitan. So, it's a busy time, and we are really lucky to enjoy these relationships, which again is due to the work of the CEOs and the facilities. Albany, they are back in session in Albany. Tomorrow is Governor Hochul's State of the State address, which really spells out her policy agenda and leads into the budget process. We, under Michelle DeBacco and my team are, very active in this space because, again, of redistricting. We've had some shifts in representation. We're doing the meet and greets, introducing ourselves and our system to these new reps, starting the process of budget advocacy, which of course doesn't technically start until January, but really starts in, September, August. So as always, we're trying to be well positioned there. There is a new health chair in the assembly, long-term chair, Dick Godfried, who was just such a wonderful advocate of healthcare and of H&H, is a well-deserved retirement. And Assemblymember Powlin, who is a Democrat from Scarsdale, has taken that seat, and we're really looking forward to working with her. very quickly on the city. Kind of no news is good news, I suppose. Again, thanks to the work of the team, we have a great relationship with Chair Narcisse, with the Speaker's office, and, we look forward to continuing that work together as we roll into next year's budget cycle, or I suppose it's this year's budget cycle at this point. Happy to take any questions.
Any questions? Yes.
On the omnibus, the Medicare cuts that we avoided,
Yeah.
do you know approximately how much that would have hit us and for how long were the cuts delayed?
I don't know. It's a pay-go, and so it's, it was kind of an across-the-board Medicare cut. I don't know, James, if we have a number on it.
I don't think we have a
I
number.
don't think we do. Yeah.
But was it just deferred?
2 years.
2 years.
Yeah.
Okay. Thank you.
I just had a question about the new health chair. Do you know anything about her? What her positions have been on health care issues?
Yeah,
Was she on the
so,
committee before?
yes, yes. So again, Michelle DeBacco on my team has a relationship with her. I believe that one of my colleagues in senior leadership has a long-term relationship with her. So, we're excited to get started with her.
I'm sorry, I just thought, did you mention, is there a new state health commissioner?
Oh, thank you for saying that. There is an acting new state health conditioner, also commissioner, Dr. McDonald, who is, has been in place, is stepping in. Unfortunately, Dr. Bassett went back to Harvard, and, it was always a pleasure to work with her. We're excited to meet with the new commissioner. Actually, Ted Long worked with him in a prior life. So a few of us will be doing a meet and greet with him later this week.
Okay.
Thank you.
The-
We'll move on to our dashboard. This is again for the period of July 1st through September 30th. So to let's think about where we have been during that period, I'd say a period of sustained high volumes of patients, but not a period of active COVID surge. Is probably how I would frame it. Since then, in the fall, the volumes inside the facilities have been increasing and remained elevated, but this is a snapshot of you hate to use the word normal operations because that it doesn't come back to that, it seems, but that is a little bit what we're looking at during this period. So the first set of positive statistics are mostly clinical, so Dr. Wade, please jump in if you'd like, but great to see the results on the follow-up appointment after behavioral health discharge. This is a very difficult measure to move, but our behavioral health teams around the system, partnering with our community care teams, partnering with Metro Plus staff, and really building in and locking in a workflow to follow up with patients. And so moving this number up above the target for one of the first times and continuing to push it will be excellent.
So the only things I would add to that is there was a lot of training about capturing and documenting this correctly within the EMR. So that's been done by OBH across the system, and that really helped. They did a deeper dive, and most of our facilities are over 50%, but there are 3 that are kind of dragging the overall number down, and so they're doing targeted performance improvement projects with those 3 facilities, to try to move this even further.
Great. Percent without being left the ED without being seen has declined a little bit, approaching that target. I'd say good to see a decline like that given the high volumes we've had, but with the increased volumes through the fall, I wouldn't be surprised to see this continue to be a challenge for us in the next quarter that we report. The most excellent result I'd say is on hemoglobin A1C control. This is our highest number ever around the system. We've increased the target to get above this high watermark for the system, but sustaining these high levels, 2/3 of the patients in control will be a real push for the year. And so kudos to Ted, Nicola, and clinical pharmacists and others on their team for an incredible achievement.
And 2 things on this one. They created a new tool that helps the staff that does the outreach to be able to better target those who are falling off. And the second piece is more epic kind of order sets and kind of care tools that are helping drive the improvement that they're seeing. So we think those are two of the things on top of everything else that we've been working on to get it from 65 to 67.
On wellness encounters, again, this is a number. It is always a mixed bag to see it go up. We're pleased that people are seeking the assistance and that we're there to provide it. It is a reflection, however, of people needing additional support from our teams around the system. So we'll look at this when we continue to evaluate what the right target number is. But good to see people taking advantage of helping healers heal and other services like that. Yeah.
Just on the first one, the follow-up appointment after 30 days this is a great, really great improvement. It's terrific, and so Eric, I heard you said some of it is just getting the records
Documentation.
right, improved. Do you have other indicators of the great improvement? Is it just documentation or?
So it's documentation, but it's also working with our managed care partners to identify the right and getting their help, the right patients, and also getting their help for follow-up. Changing it so that telehealth visits count as well was something that happened during the pandemic, and that's helped us boost numbers. But it's been a QI project for OBH, our Office of Behavioral Health, for a while.
Right.
Omar Fatal, our new lead for OBH, he actually used this as his capstone QI project for a fellowship, a quality fellowship that he was in. And so a lot of training, a lot of audit and feedback, but targeting these 3 facilities now and having them come up with additional quality improvement projects is the next step.
Right. And what about in terms of sort of capacity for is that, I mean, I've heard, is that continuing to be a problem, and how is that going to impact our drive here?
Yeah, I mean, it is a continuous challenge for us in terms of provider staffing for psychiatrists, but working to see if we can increase kind of nurse practitioners, APPs, psychologists, pharmacists to kind of offload. I think that's how we're going to try to think creatively to take things off the plate of the psychiatrist so that they can do things that only psychiatrists can do.
Thank you.
Yeah, I just wanted to say congratulations on that as well. Behavioral health, that's, very difficult. Any improvement's a great improvement, and I think the numbers are phenomenal. So congratulations on that. As far as the 0.2% movement on leaving the ED and hemoglobin A1C, I'm a big fan of just not going below where you are is a big win sometimes. And just to keep moving in the right direction is still a success.
Yeah.
So I want to say that's also a good thing. So don't give up. Cultural safety, total wellness encounters. I think it's, post-pandemic, people really struggle sometime with this, and I think everyone's taking a lull right now on this. And you seem to continue to move. So that is very positive too, and I don't know if you are aware compared to the other systems how you're doing, but you are moving in a positive, way more positive direction than they are. They're involved in other things.
We are our own toughest critics sometimes, so thank you. That's
Yeah, you should
hear.
Okay.
Okay, well, on to the next set of positive trends. Access to care. This is one of our favorites and most important. The unique primary care patients is up 13,000 for the quarter. That's excellent. That's the front door of our system, the foundation of building value-based care into our system, and so that is great to see. On financial sustainability, continued improvement for the post-acute team and just their accounts receivable and basic work on billing and following up. And then our largest IT project at the moment, the enterprise data center migration, remains on track, and I think is 66% of the way through the entire project. From here, we have steady trends and then areas for improvement. So on financial sustainability, one of the measures we track, as you know, is the percent of uninsured patients who are not only receive financial counseling, but from that encounter are either enrolled in health insurance or in financial assistance. That remains at 88%. Significant improvement over time, I believe, from 70% a year and a half ago. So this is a great sign that we are really engaging with all of our uninsured patients and helping them find the right benefit package for them. But the target is 90%, and I think we have to continue to push that up.
But if you go back to like 2018 or so, how would that number look like? How many of the uninsured folks would not have access to either
2018
insurance or financial?
would be difficult to say. I don't even know if we were tracking it then. The earliest number I remember tracking was in the 60s or 70s.
60s.
The key measure for me was, I think at a certain point, the percentage of uninsured patients who even had a financial counseling visit of any kind, right, did they speak to someone, was in the 50s or 60s. So this is a change in the metric, which is important because it's not just did you check in with someone, but were you enrolled in financial assistance? Were you enrolled in insurance? So it's that next level of engagement that Allison Hartman, Margie Carlin, and our teams around the system have worked.
So that 12 percentage point then is people that don't want to enroll in anything. That is it that they qualify for insurance and they don't do it, or is it that they qualify for financial assistance and they say I'm not going to bother with it?
It could be both, or it could be that they are in for a visit and their check-in time for the clerk is 30 minutes before the visit, but they arrive 5 minutes before, and the providers and teams just say, let's just move on through. We'll get you in, have you seen, and you can follow up with someone after the fact. And whether that follow-up happens sufficiently is a question. So the key is to try to move all this stuff before the visit as much as possible. Advanced visit planning, doing it over the phone, doing it through MyChart. So it could be those things. It could be people who don't want to enroll in anything. It could be people who just aren't spoken to and have their clinical visit without that contact.
I think our financial consulting, like some interactions, is really, really high. If I'm remembering from some of our updates from Margie, right? We're in the maybe 90 percentile or higher.
It's very high. And on the inpatient side, I think it's over 98, 99%.
Right.
So this would almost all be outpatient or ED.
I see.
And just hundreds and hundreds of thousands of visits. So if a few slip through, that's where it comes from.
I think getting a sense of why, what's going on there. That is it. I mean, you have many hypotheses in a way, right, of what drives it. But for example, language. Is it language difficulties? Is it the type of emergency that they come in, that they just, I don't know, go somewhere else? I don't know.
Absolutely, yep. We can try to break down that 12% a little bit further. I'm sure Allison and Margie have. It's all tracked in Epic and should be knowable to a degree, but definitely the people who we can't hang on to sufficiently in that process, or the process is too rushed to have a full enrollment for them. So we'll get that breakdown. And then the next financial sustainability measure, total accounts receivable days, remains steady. I think some of this is just our underlying billing operation, and I think it remains pretty steady. We've had, with the name change to South Brooklyn Health, with some other things, we hold bills as certain things change, but I think that overall measure and the returns you'll hear more about in the Finance Committee and have been very good. On to the next slide, a couple areas where we dipped. Patient care revenue over expenses was at an all-time high of almost 75% and dropped to 73.3. Really think this is a timing issue of kind of when risk settlements and other things have come in versus expenses. It remains higher than our target of 65% that we wanted to maintain because of the changes in our cash flow during COVID. We do not know if these 70% numbers will be sustainable. We'll continue to watch it very closely. Similarly, on the percentage of Metro Plus's spend at health and hospitals, that 44% was an all-time high, driven by some risk surplus payments and other things in that timing. So to see it dip to 42% is unfortunate, but I don't think a reflection of any decline in partnership or work together with them. We have a lot of good work going on, partnering with them on home care, partnering with them, as I mentioned, on behavioral health, and in a lot of key areas to grow primary care access and other things to continue to work together with them on the massive expanded new membership they have, over 700,000 for the first time ever. On access to care, e-consults, fairly steady, just a 2,000 drop in the quarter and better than the target of 95,000. I think this remains a reflection of how many specialties we are expanding this to and what the workflow looks like in those to take advantage of this technology. Overall, we have work to do on the speed of processing our referrals and of the percentage of our visits that we want to do through e-consult. So we will see if this target is going to be adjusted up, higher into the hundreds of thousands, or if we have more work to do on just the underlying workflow of how specialty visits are done before we can revisit that and raise the target much higher than it has been. Similarly, on NYC Care, as a result of the kind of re-enrollment cycle at the beginning of the year, the numbers did drop a little bit. The 6-month residency requirement is no longer in effect. And so I think this should come up as the year goes along, but may not exceed this 113,000 that we hit last quarter. That may be a kind of high watermark for us given how many people are eligible and where that stands. So we will track that closely, but remains above the target of 100,000 and an award-winning, successful program for us. It's great to see. On the next slide, a slight increase in the hospitalization rate coming out of post-acute care. They did a deep dive on this, I believe, and it's not a large number of hospitalizations, so any small move can drive an increase. But I think at each case they looked at, it was not avoidable in the quarter, but they track closely and will continue to work on it. Eric, I don't know if there's anything on that.
Yeah, we're just hoping this is common cause variation of bouncing up and down. But if it becomes a trend going up, we're gonna have to do a deeper dive on it. But as Matt said, Dr. Long and the post-acute care team, they look at every admission, and they seem like they were indicated.
Great. On our care experience measures, very important and driven in large part by the volumes of patients we are seeing, kind of inversely related, unfortunately, at sometimes. So our inpatient care rating did dip from 63.2 to 61.7. That is below our target, as did our ambulatory care outpatient measure dip from 85.4 to 84.2. This will be, I think, a challenge in the next quarter that we report, which will be a busy one through the fall when volumes were very high. We have not been in any large numbers actively redeploying providers from the ambulatory side onto the inpatient side, but we are busy. And as we are busier, I think it is not as good an experience as it could be for patients, and so some of that frustration shows up in these measures, rightly so. I think our work, driven again in partnership with Metro Plus, with Health First, with others, on our provider patient satisfaction scores, how we're following up with people, will be a big push in 2023. It's really foundational to who we are as a system, what we want to be, and selfishly as a kind of finance managed care person, it's foundational to our financial success. A huge percentage of our value-based revenue is tied to patient satisfaction, and so we need to think about it as a financial imperative, which in some ways is useful. So that will be a focus for this year and more to come on that.
Matt, that's Michelle. Any correlation between physician and staff burnout and patient satisfaction? Have we looked at that at all?
I mean, I think we've looked at the literature nationally on it, and it's certainly there. I haven't seen a kind of internal study that we've done. Our medical staff office may have done internal research on it. It's certainly a national trend, and it wouldn't surprise me. I don't know if it would surprise you internally if it
Maybe
is.
we can work with Jeremy and
So we have our employee engagement survey, 2021, 2020, and it does show the effect of the pandemic on burnout. And absolutely, right? If I feel less well, I have less empathy and less kindness to give to my patients and to my colleagues. And so that's been a big focus of our workforce wellness. Let's take care of our people so they can give their best to the patients. But I think these numbers are a direct correlation to the volume that we're seeing, right? Boarding patients in the emergency department, that's not a good experience. That colors the rest of, right, their stay. It also affects kind of the experience of everyone else in the waiting room, those who are leaving without being seen, those who are, giving their care in the hallway, in chairs in the emergency department. So it's all kind of volume driven, we believe, and so we're working on the length of stay improvements, working on our ALC patient improvements. While we're working on that, we are rolling out both for the ambulatory and the ED side a pop-off valve of using virtual express care kiosks. So if I walk into my pediatrician's office and the pediatrician's already added 6 patients to a full schedule, they can't fit me in, instead of sending them home and saying, we'll call you or come back, there will be a kiosk there that the parent and the child can log into virtual express care right there and get an evaluation virtually. Obviously, if they identify something that needs to be seen in person, they'll send them to the pediatric emergency department. And we'll do the same things. We're working through some of the legal logistics of this, but we want to pilot in multiple of our busiest EDs, almost like booths. You think at the airport, the breastfeeding booths, right? So some privacy with a kiosk, right? And have criteria for patients that we're going to offer a virtual visit to so they don't have to clog the rest of the downstream ED process. So trying to think outside the box of innovative ways that we can decrease kind of the overcrowding that we're seeing.
Right. So I'm concerned because we've been seeing some complaints, and it seems, I don't have the data, but it seems that it's increasing. And I don't think our providers have taken vacation since the pandemic. So I'm actually wondering, included with the increased volume and increased acuity, that our diminished scores in patient satisfaction actually may more significantly represent where our providers are in terms of burnout and ability to be empathetic and compassionate.
I had a similar question related to the post-acute care hospitalization increase, whether there were changes in the care that we provide in any way that may be driving that, because those are unavoidable, right? I mean, so it may be like uncontrolled hypertension or diabetes or something like that, yeah.
I don't have the breakdown of the cases in front of me, but we could definitely follow up for next time on those. But absolutely, right, it affects the experience, affects the care. You want somebody who is 100%, of themselves, making the clinical decisions, doing the procedures, talking to the patients. And so absolutely, I think we're just seeing, right, we're continuing to see the effects of the pandemic on the healthcare workforce across the country. We're no exception to that.
Thanks, Eric.
Thanks.
So the last measure on this page is MyChart activations. We are at 66%, which is close to our kind of national leadership numbers of the past at 71.3. It is dipping below our target of 75, so we need to look at this a bit more carefully. The number of COVID tests we did and the sheer rate of activation we got from people through that has declined, but making this a more common part of not just our primary care patient visit, but an ED follow-up. All those different things are I think the next key moves that can get this turned back in the right direction, but still a very important thing for us that over 2/3 of our patients are actively using MyChart.
I had a question. I discussed two things. First, the kiosk. I love that idea. I mean, I think that's amazing because it gives people an option. You don't have a sense of helplessness. I'm just going to walk away and despair. You have an option, and I think that's marvelous. on the MyChart activations, Eric and I discussed briefly how we're doing on response time and whether this could be reflective of patients not feeling responded to quickly. And Eric has some information.
Yeah, I have some more information to share. So we do have a MyChart steering committee. Matt, myself, John, um, Ted are all kind of on the leadership group here. And there's an entire dashboard that's aligned with our 5 strategic pillars, similar to this one. So I know the one that's on here is the activations. That was the kind of number that we were cheering up, up, and up. And now it's kind of plateaued and come down a bit. We suspect some of that has to do with the patients that were only using us for testing, and the only way you could get your test result was to log into MyChart. So that's not a surprise. But we are looking at utilization as well. So not just MyChart activations, we're looking at message handling, um, percentage of messages handled within 3 days. And over the last 3 quarters, 66.8%, 67.2, and then a dip to 59.7. I suspect this has to also do with increased demands on our ambulatory care providers and our specialists from the increased volume. We saw our primary care numbers go up, and still trying to dig out of the hole that the pandemic did, but we need to watch that closely because, right, why sign somebody up if we're not going to actually respond in a timely manner there? So that is something that the team is looking at closely. But just to look at, let you know that we're being thoughtful as a steering committee about other things around MyChart. There's MyChart tool utilization percentage of appointments scheduled by the patient through the portal themselves. So rather than calling, uh, to make an appointment, they're making it themselves. Open notes. So this is patients going in and looking at their own notes. E-check-in. So doing all your paperwork before you even show up to clinic is another metric of ours. And then logins per user. So are they just going in because we told them to sign up and then never logging in again? And that numbers remain consistent, 10.9, 10.6, 10.8. So most users are going in, over 10 times over the course of the year. So that's encouraging.
It's wonderful. It's great to have all that data. Thank you.
Great. On to the next slide, some of the measures of our work on racial and social equity. The percentage of our new physicians who are hired from underrepresented minorities is presented here. In the note, you'll see the major data challenge with this is that almost 50% of our new physician hires, their racial and ethnic information is unknown because of missing information. That is a more than 10% improvement from the last quarter. So we have, we are driving that number down to get the right data that we need to track our progress on this, and a lot of work to go for us, for the medical profession as a whole. But we'll continue to push on it and try to lead on it in important ways. And Eric, we have a new measure on equity lenses and performance improvement. Do you want to describe that a little?
Yep. Yep. So that was moving from kind of the quality assurance piece, our existing chronic disease dashboards, through population health. They really led the way on this is how we apply equity lens to our dashboard. So that's on the quality assurance side. But we've also been working equally hard on the performance improvement side. And for those who join our QAPI subcommittee of the board are seeing this, it's on our new PI charter, it's on our balanced scorecard metric selection, it's on our one-page summary as well as our QAPI template. And the idea is that for any performance improvement project, you proactively identify an equity lens that you're going to apply to the outcome measure. So we'll track to see if any disparities get worse or any disparities are identified. And the idea is that as you're doing the project, the subsequent tests of change or PDSA cycles should address closing any of those disparities. And so in Q4 22, we had 40 that made it into our QAPI reports that came to the board. The reason that only 8 are showing up for Q1 is because we're still in that cycle right now. So we haven't received all the reports and had all the presentations yet. But this is something that is very encouraging, and then we hope to have this evolve even further to where performance improvement projects, the aim statement is actually or addressing a health disparity maybe unveiled by a previous PI project, right? And that we provide more capacity building and training on how to create PDSA cycles that address health equities or disparities. I think is something that we have planned for 2023 and beyond.
Yeah, that's I see it on the, well, we see several of us at the QAPI meetings, and it's pretty impressive how the data is being presented now and how sometimes some of the conversations go into like, are you using the appropriate groups or metrics depending on the issue that you're addressing, and it's almost like a work in progress. So it's great work on that. I had a question on the previous one on new hires, and it has to do more on, I understand that the numbers are off and so on because many people don't report. Uh, um, but it would be interesting to know more than the numbers, the effort that we're putting into recruiting different diverse workforce. So whatever it is that we're doing, like, are we advertising in or working with organizations that can help us with that? Are we using search firms that are attuned to that? Anything like that? It would be useful to know that information to put those numbers into context.
We can add that.
We can have maybe the Mosaic team give an update. So this is under Michelle, Natalia, Nicola, Donnie Bell are leading they're calling it Mosaic because it's multiple programs coming together as a mosaic, but targeting as young as, right, middle school, high school students. Deb, sorry, you're a big part of this too, and John Olberg. But targeting them to provide the mentorship, right, role models that are physicians and healthcare workers, but starting with physicians, targeting those that are in medical school and paying for them to come to New York City and feel our mission here as an external rotation, and targeting schools that uh, University of Puerto Rico,
Morehouse.
Morehouse in Atlanta
Yeah.
is the other first two that working with, as well as residents, right? Can they do an external rotation in whatever specialty that they're training in? Here we provide housing, we give them a stipend for the cost of living for that month in New York City. But we think exposing to our providers, our patient population, the mission, potential mentors and role models, how can we increase the pipeline, right? Partnering with Mentoring in Medicine, which is a very successful program here in New York City. So it's not fighting over a shrinking number of underrepresented minorities, right? That tends to be seen as creaming off the crop. You give them a full ride to Columbia, they want to go to Columbia, right? But it's not increasing the total number of future, right, underrepresented minority doctors. Mentoring Medicine is getting those that are not getting into medical school, and how do I help them get into medical school? And so we're partnering with them as well. But that's kind of my external knowledge of this program. I know Michelle, Deb, if you want to add anything to that.
So we're focused on improving the pipeline, but I don't know what we're doing from an HR perspective. If we have recruiting firms that are helping us identify.
Yeah, so the affiliate has several strategies in place, including recruitment firms and organizations that are that have a minority focus to help them as well. And we can, we'll add that to the next presentation.
Thanks.
I think it would be very interesting to have, if we could, a briefing of the mosaic. I think this came up in EDI.
I think we're planning on having a presentation to the board. Two things. One, I forgot who asked for an OBH, a behavioral health presentation of all the things. I think it was Vinny who asked. Or you asked, yeah. All the work that's being done in behavioral health. So that's a presentation that's being planned for the board, and Mosaic as well. Board presentation.
Yeah, I think the pipeline issue is really really key, and it's great to hear you're doing all this. And there's what did you say, creaming off the I like,
Yeah, creaming off
yeah,
the top.
that's not
so,
what
yeah.
I think is going to really change the
Very
landscape.
challenging.
It looks like your Latino number went up pretty significantly from when we started. Maybe that's just my memory, but 5% seems like a good number.
Yeah, you have to remember this is just that one quarter, right? So these are all the new providers, physicians that were hired between July 1 and September 30th.
I just have a question on the non-reporting. Is that because we ask and it's self-reported and people are choosing not to report? Is that why we have?
So the required reporting mechanism. H&H has from the H&H employer side, we have a very high rate of people that report.
That do report?
Yes.
Ah.
It's really on the affiliate side where we struggle to get the information from.
Is that because they're not asking, or we don't know?
Somehow they ask, but somehow it's just not. I don't know what it is. When we ask for information, we ask as a bundle, as part of your employment process. So maybe people think, like, there's more like response to us.
Right.
And we follow up very gently with people to disclose, and so it's different in that sense.
Okay,
We got 20 minutes.
great. Our next slide is a suite of COVID-19 metrics. I'll highlight the new ones that we've added here, which I think our proposal is to focus on these in the months ahead. More reflection, I think, where we are with the disease at the moment. We have included the percent of our beds that are occupied by COVID-19 patients. So that was a slight increase from 3% to 5% in Q4 of last fiscal year to Q1 of 2023. And the other two are measures of treatments of our central role in no longer test and trace, but test and treat. So the number of oral antivirals that we provided jumping by about 30%, and the number of infusion treatments we provide jumping by about 20%. So those are two of the key ways through virtual express care, through our work with the rest of the city, that we are fighting back on this terrible disease now, and I think probably more instructive for us in the board than just the raw testing numbers and other things we track. So those are three that we'll look at with your permission going forward in these meetings, and remains central to how we are responding here. The next slide is another piece about next steps, just how we are proposing to, I'd say, mildly tweak our dashboard and our work together with the committee in the quarters ahead. As you know, we have our community health needs assessment and the implementation plan, which again for us, as Deb has so eloquently and correctly said in our meetings, is not just a report to sit on a shelf. It really is our strategic plan and our guiding document for the system. So in these reports, we'll try to some degree merge our strategic pyramid and the key priority health needs and implementation plan goals of the community health needs assessment, and start to spotlight some key programs and steps we've taken to achieve those major goals in health equity, chronic disease, and facilitating access to services. And we will, I think in a longer term process, look at updates to the strategic plan pyramid and the individual metrics we report. Luckily, I think the dashboard we are reporting on now is very closely aligned with the work in the community health needs assessment and the implementation plan. But we want to keep those key metrics that we heard about from our community, from our patients, front and center in what we are reporting to you as the strategically important metrics for the system. And that really.
I had a quick question. When it comes to lifestyle behavior change for chronic disease, are you thinking about it as information that is provided or interactions between, say, physicians, nurses, and patients on the clinical care side, or you're thinking about like provision of fresh fruits and vegetables in the lobby of a hospital and so on, or a combination of both. I'm trying to understand the one thing is counting a few things, the other one is like really thinking about like how to change somebody's behavior.
Yeah, no, I think that's a really great point, and I think it goes back to a conversation I know we had, and a number of us had repeatedly when we were formulating the community health needs assessment, which is, sort of identifying what is H&H's responsibility or ability to manage, and then what is important to the community, and it is our requirement or, our obligation to build relationships with those who can provide those services. So I think yes is the answer to everything you said. I think, there's been an increase in how our clinicians work with their patients on things like healthy eating, and, there's really some wonderful stuff going on under Dr. Ted Long, Dr. Andrew Wallach, many more that I'm sure I'm missing. In addition, we do have things like farmers markets at our hospitals, and that's something that I think is really important. We work with our colleagues in population health to kind of identify programs that can be useful to our patients, but there are things that are not an H&H solvable problem. Things like green space, things like parks, things like, access to sports, which is something that the mayor is really going to be focusing on coming this year. And so there, what we try to do is partner with CBOs, partner with other city agencies. But I do think knowing that line of what we can and should do and what is not really ours to do, I think that's an important part of this process.
So I'm thinking that later on, if you can talk about like how the clinical encounter is being sort of like not, I mean, change or rethought or anything like that would be interesting to know, just so that as you implement it.
Yeah, just from an obstetric perspective, so much happens in the community. The patients come to us with their chronic diseases that haven't been addressed. And so there's a whole, and I know the pediatricians are looking at the child when the child's a fetus. Well, how can we address obesity from the maternal perspective? So it's so variable, our health outcomes. And, we, with our social workers and our community outreach workers, we're looking at the other determinants, what we call the social determinants, which are very well in terms of food insecurity, housing, access.
Jobs, economic insecurity. I mean, it gets very big very quickly, appropriately so. And I think one of the things that was really interesting and compelling to me in the CHNA process is that it was members of our community speaking very, very in a targeted way and in an eloquent way about those things. These notions are not lost, outside of the academy.
I think trying to solve it all in one shot would be very difficult, right? But at the same time, if you have some examples on, like, for example, this is the way we dealt with housing before and how we do it now, or food or legal issues or whatever it is, a few examples.
Okay.
Because it helps you sort of like focus on things you can do, right? Rather than trying to solve everything.
And I think it's, our collaborations with the other agencies in the city is very helpful. And I think we've made a lot of progress under the leadership of Dr. Katz, who famously says you can't have health without housing if you don't have a home. So that kind of collaboration, cooperation across agencies is something that we can document.
And we really, I don't mean to sound like completely Pollyanna, but we really do have some wonderful relationships with other agencies that, Dr. Katz has built, I have built, Matt has built, others have, Dr. Allen. And, we all want to do the same thing. It's sort of a matter of how you get there.
Great.
Takes a village.
Takes a village. Takes a city.
It takes a city. I like that. On that note, that is
T-shirts
our
coming
presentation.
soon.
Any other questions we welcome, but thank you as always for your support and guidance, and we will keep it going.
Any other questions? No? So any old business or new business to come before the committee? Hearing none, then the meeting is adjourned. Thank you so much.
Thank you.
Thank you.